and then press start. Hello and welcome to the second in the Falls Awareness Week webinar series for 2023, and today's title is Innovative Strategies to Reduce Stroke Patient Inpatient Falls with Madeleine Gifford from Hillingdon. So a little bit of housekeeping first before we actually move on to the presentation. Earlier in the year we decided to title this week's campaign as Awareness into Action, and we did a call to arms for the grassroots projects to come out of the undergrowth and to be shared, and we've been very lucky with some really good presentations coming up. We've already had one, it's today's, and we've got 3 more actually during Falls Awareness Week next week. My name's Neil O'Halloran. I'm the clinical support at Medline Industries, and I have a specialist interest in falls, and so much so I created the Falls Prevention Network 6 years ago, which is how working with Simon that the whole Falls Awareness Week rekindled. We're now migrating to the future NHS platform, so that's a very interactive place with lots of resources. If you're interested in joining that and haven't done so already, please contact me. I'm ably assisted today in the background. You may hear but not see Simon Durson-Smith and also Audrey Cope. We will be dealing with managing the Q&A sessions. This event will be recorded and it's available to view via this very same link shortly after the event. So if you've missed it, let a colleague know, they can join it, or if you want to watch it back because you liked it so much the first time, you can do so. All mics and cameras are going to be set to off, and if you've got any questions at all, pop them in the Q&A panel and we will review them and collate them, and then we'll feed them back to our speaker at the end of the presentation. So there'll be a presentation from Madeleine Gifford, who is the specialist neurophysiotherapist at Hillingdon Hospital. And when she was working on the stroke unit, she noted a high incidence of falls where she was working, and she designed a quality improvement project to address this issue, which has some fab results that she's very keen to share. Maddie and this project have become well recognised in her trust and have already presented this project to her Hillingdon colleagues via a podcast. So Maddie is here today to share her experiences with you all. A bit nervous, but all good thing is she can't see or hear you, and we're all friends here anyway. So enjoy, and over to you, Maddie.
Thanks, Neil. So hello everybody, thank you for coming to this presentation on the project that was run on the stroke unit here at Hillingdon. As Neil said, I'm a specialist neurological physiotherapist. I qualified 2 years ago in 2021, but I knew straight away that I had a particular interest in stroke and neurorehabilitation. But I did do my band 5 rotations and I took up my specialist role in 2022. And I started this project a similar time, and let's get started. So what we'll be covering is the project. I wanted to look a little bit at the relationship between falls and stroke patients. We'll have a look at, it's a quality improvement project, but I did a little audit of the day texts that I'll explain that a little bit more. So what we did, how it impacted the ward, and conclusions that can be taken from that. So a little bit about the project. So the stroke unit had moved to a lovely new modern ward as a part of the new rebuild of Hillingdon Hospital, and upon moving there, the team were concerned that the number of falls had almost doubled, and I was also particularly quite interested in finding out why the falls had doubled. It's important to investigate because improving patient safety and service development should be utmost. And it was also a bit of a personal interest of mine, so I had to look into it. So first, a little bit around the relationship of falls and stroke and why preventing falls is such an important thing that has to be thought about in acute stroke care. So the first being that falls can be the #1 medical complication following a stroke. And to add to this, a stroke patient is more likely to acquire a fracture, and it's usually on their affected side. This is something to do with bone mineral density and reduced weight bearing post-stroke. Post-fall, a stroke patient is more likely to experience fear of falls, deconditioning, reduced activity, have a look at this flow chart, which I took from an article from Falls in Individual with Stroke, and I think that what it does is it highlights quite nicely the relationship between stroke, falls, and the cycle, the vicious cycle that can occur. So someone has a stroke, they have a decline in physical activities or cognitive or visual impairments, they have a fall, this then leads to fractures or fear of falling, and it all comes down round again: reduced physical activity, decline in physical activities, fall, and you see that this can become quite a vicious cycle for some patients. So I wanted to have a look at the research that is currently available, and what I found is that there isn't too much out there, but this is some of the information that I have found. So one paper stated that falls seem to be a known risk and complication of stroke, but there's not a lot of research into why it happens and how to prevent it. And the figure in this paper was that 85% of falling patients are reoccurring. And this was quite shocking and astounding to me, as it shows that more needed to be done to learn from a patient falling to prevent the same from happening again. Another paper showed that 65% of patients would have an inpatient fall during rehab, and this in turn, I think that if there's any therapist among us, that you know the kind of impact this has on our patients' rehab. Generally, it can increase their fear of falls, likely impacting their engagement with the therapists and wanting to try anything new in rehab. So you can see why this is quite a shocking number. So from the paper of falls in it, sorry, so from the paper Patient Falls in Rehabilitation from 1995, it was a study that looked at an acute stroke unit in I think it was Switzerland, and it showed that 61% of falls on their unit was unwitnessed. And this is something that we found on our unit as well. A lot of people were falling, and we couldn't explain why, because it was just not seen. The paper identified that early identification of those most at risk of falls was the biggest preventative preventative tool. And the same paper also had a look at the causes of falls and identified these categories here. So extrinsic falls, which is an external factor affecting the fall; intrinsic falls, which is something inside, like dizziness or vision affecting the falls; non-bipedal falls, which was a fall from a chair or a bed; and unwitnessed or non-classifiable falls was also a category that they had. And it was from this research that I had a look, and attending some fall seminars that I helped develop the fall prevention tools that I go on to speak about. Something I wanted to add on is that there was a quote in the same paper: "It seems inadequate that patients with serious cognitive impairments are expected to understand and remember verbal instructions regarding ambulation and physical activity." And I found this quote quite interesting, because to me, I interpreted it as there appears to be some lack of understanding, even amongst healthcare professionals, of the full impacts of stroke on an individual. And reviewing the daytexts, it seemed to be evident as well. So as a part of plans to build the new hospital, the stroke unit had moved to a new building with a new layout. And as I said before, the team and I were concerned that the number of falls had almost doubled. The only thing that had changed was the ward layout. The same number of nurses, the same number of patients. The audit of the old unit showed that there had been seven falls in three months, and 4 of those were described as patient found on the floor. And in the new unit, in 3 months, there was 13 falls, and 9 of these falls were described as patient found on the floor. So that said to me that they weren't witnessed and the true mechanism of fall was unknown. It was thought that there was a problem with visibility, so patients weren't being seen getting up by themselves or fatiguing. So let me just put a bit of context behind this. So I've got here, this is a layout of the old ward. So you come into the ward here, the gym is here, A bay, B bay, C bay, D bay. Oh, let me just go back. And this is a corridor. So you could see A bay and B bay from here. You could probably see quite a lot in these spaces, and the side rooms were right behind the nurse's desk, so you had good visibility into there as well. And then if I just go on to the new ward layout, so you come into the unit here at the front desk, and here are this is the corridor, and these blank spaces here, that's their walls. So as you can see, it's very different. So you've got A bay, B bay, C bay, D bay, and then all of these side rooms. So there's 4 patients to a bay, and the nursing staff in B bay, for instance, will look after the 4 patients in that bay, a nurse and a HCA, but then they also have to look after side room 7 and side room 8. And you can see the problem in that when they are attending to these side room patients, and stroke patients usually need 2 people to help them get washed and dressed, in and out of bed, that sort of thing. So when they're attending to these patients, they can't see their bay, they can't see the patients that are in there, and vice versa. So you can see the challenges that we had. So we had the increase in falls from 7 to 13. So these are the themes that was highlighted. So in the June to August in 2021, the themes that were highlighted: fatigue, loss of balance 2, patient non-compliance 3, medical condition 1, unknown 2, and walking unassisted 1, and agitation 1. And if you look over at the 2022, the numbers are quite different. So you can list more than one contributing factor for the fall on the Datex report. So you've got here fatigue and loss of balance, that's gone up to 4, and the unknown has gone up to 4, walking unassisted has gone up to 2. We've also got other listed, which is 3, which could be non-specific, maybe they were thinking of something else, could be also it was unknown. Something that I found quite interesting is none of the contributing factors was listed as stroke, and stroke is one of the contributing factors that you can list, and none of the patients who were included in this were medical outliers, because we have medical outliers on the stroke unit. All of the patients that were included in this audit were stroke patients. So the link that I've put into this is that there was an increased number of unknown, there was an increased number of fatigue, there was an increased number of walking unassisted, and an increased number of other. So I thought that it might be linked to the visibility, because patients could have been in the side rooms and are trying to get up by themselves, or in a chair and feeling tired and aren't able to call for help, or don't have the insight to call for help to say that they're getting tired. So yeah, so these are the conclusions. So the data showed that the falls there was more falls on the new unit compared to the old unit. The majority of the falls happened at night, and they were unwitnessed, and I felt that there was a link between the reduced visibility, and patients weren't being noticed if they were fatiguing or trying to get up because of that reduced visibility. So a few solutions were proposed. So one of those was a traffic light system, a flow chart, and falls alarms, and then bringing in a falls huddle. So traffic light system. So everybody has heard of some form of traffic light system. What I wanted to do was adapt it to take into account all of the problems that we have with stroke patients. So I looked at including the PAS outcome measure, which is postural assessment scale for stroke, and I looked at people's agitation, people's sitting tolerance, what assistance they needed to get up, their insights, if they were aware of their physical impairments or cognitive impairments or visual impairments. And that's something that I found that hasn't been included previously. So something that we did notice is that patients who would score low on the PAS, the most impaired patients, they were sometimes our more drowsy, low arousal patients, full hoist patients to tilt in space chairs. They were being flagged as high falls risks when in reality the patients, they wouldn't have the initiation or the alertness or the ability to try and get up by themselves. So this is something that I want to look at and adapt. I haven't had the chance to yet. And when we would categorise these patients, this was up in our office, when we'd categorise these patients, we would do that on initial assessment, and then we would get a coloured disc with a falling man in it, and we would stick that above the patient's bed, and we would hand it over to the nurse that what their transfer method was, what their seating was, and what their falls risk was. So moving on to the flow chart that was developed. So an issue that was highlighted when reviewing the datexes and discussing with the team was that when patients were being repatriated to our hospital from Charing Cross or Northwick Park, the falls risk level was not indicated in the handover, and therefore patients were being put into the side room and consequently not being observed as closely and possibly falling. So this flowchart was created by myself to help give the nurses a clear system to help identify the most appropriate bed space available. So I thought about the questions that we want to ask when considering a patient's falls risk. So cognitive deficit, can they call for help? Do they have the insight to call for help? And do they have the physical ability to use the call bell was something as well that I took into account. They can ask these questions over the phone, and when they're doing the handover, and use the flowchart to identify which bed space is more appropriate, and that way that when the patient arrives, they are already in the best place for them. This was also used to review current patients on the ward if anything had changed. So if the patient had developed a delirium and they needed more monitoring, or if their delirium had resolved and they needed less monitoring and someone else needed to come into the bay. Of course, if someone had an infection and required a side room, then that took priority. So if there was no bay available, this advice was given to the nurses and the team. If you think about the ward layout, so side room 3 was the most visible, so patients should be placed in a more visible side room if possible. Monitoring the patient regularly, using falls alarms, giving visual prompts to the patient to call for help, making sure their call bell was by them, if they needed something written down for them, and if all else fails, considering a one-to-one. So we also used falls alarms. So the falls alarms that were in the equipment library available to the whole hospital were used. These alarms had a pager and a transmitter, so that if the nurse left the room, the pager would buzz so that the nurse could feel in her pocket or his pocket that the patient was getting up. So a patient would sit on a pad, or a pad would go underneath the bed, and if they tried to get up, then it would go off and the nurse could respond to them. We did find that we had some issues with these, as they were very, very sensitive, and they would go off sometimes just from a patient adjusting their bottom or rolling in bed, and that. So sometimes the alarms were going off a lot, so that it was a bit of an adjustment period. They're also very loud, so if anyone was in the area, it wouldn't necessarily have to be the nurse, someone could attend and help the patient. So the falls huddle was brought in actually a little bit after this, but this was brought in as a result of attending a falls conference which discussed that the best preventative tool to prevent falls was learning from them. So immediately after a patient had a fall, once they had been reviewed by the doctor and was made safe, a meeting took place between the nurse or HCA that was present at the time, lead therapist and the doctor, where we would discuss the fall and talk about what happened, what are the learning points and any actions from this that could have been different to prevent this fall. And this was completed with the aim of changing practice to help prevent the same thing happening again, because as discussed before, where in the paper of the study that was completed in Switzerland, I believe it was, 85% of fall-related incidents were reoccurring fallers. So this is looking at preventing that. So, and then on our unit in the review, 4 of the 13 patients that fell were reoccurring fallers. So these are the results of the audit. So in the yellow, we've got, this is on the old unit, and this is seven falls here. This is on the new unit, and this is 13 falls, and this is on the new unit but post intervention. So you can see that we're at 8 falls. So there was a big improvement in the number of falls that were happening. So looking at that a bit more, so there are 8 falls in 3 months. 2 occurred during the night shift and 3 occurred during handover time, possibly when the nurses were outside doing handover at the nurses' station, or when attentions were on other things. One of these falls occurred in therapy, and in my mind, of course it counts, but in my mind, that's, yeah, I'm not sure what I mean there, but yeah. So there are some similar categories that were highlighted, but there appears to be a reduction in the categories that were directly linked, that I linked before to reduce visibility. 2 of the patients were reoccurring fallers, so we went from 4 to 2, and only 1 patient was being described as found on the floor, which I felt was quite a big improvement. So these are the themes that was highlighted. So agitation was the same as before. Dementia was a big one this time, 6. Medical condition 2, other 1, non-compliance 1, confusion 1, stroke 1. There's no highlight of unknown, and there's no highlight of highlighted theme of patient trying to walk by themselves, or fatigue is not highlighted as a category or a theme. And so that was a reduction in those categories or themes that I'd linked to visibility. And again, only one of the highlighted categories was stroke. And again, all of the patients that were in this audit or this review were stroke patients. None of them were medical outliers. So, and I think it's worth mentioning that in this review of December to February 2023, we had a bay which had a whole, it was cohorted bay. All 4 of the patients in that bay were extremely high risk of falling, and the patients in the side rooms were also high risk of fall, so they were regularly brought into the bay, and none of those patients were included in this review, which I felt was quite good, and it was fed back to the team that none of those patients were on that review. So looking at the whole project, so since implementing the strategies, there was a reduction of falls from 13 to 8. there was more known about the falls. There was more information on the Datexes regarding the mechanism of fall, which said that there was more witness falls. The overall awareness of falls and the vigilance around falls I felt had increased. And something that is very important to mention is that it took the whole team to take an active role in this falls prevention, to see a noticeable change, because using the traffic lights, the therapists, we could highlight the ones that were at risk of falls, and then this allowed the nurses to cohort the patients more easily and put all their red patients in a bay, or knowing that they've got a red patient in a side room, and that so it took a whole team to be able to prevent the falls. And it seemed to me that early identification, the same as the paper that I'd read, was the best preventative tool in preventing falls in stroke patients, and education for everybody around falls in stroke patients and stroke in general was important as well. So we had a falls board that went up, or a falls prevention board that went up, that relatives could look at. Education amongst professionals, amongst patients, was really important to ensure that those individuals at risk were well understood. So here's the references, and that's the project. So if we can move on to the questions now, if there is any.
Thank you very much, Maddie. That was really, really insightful. And one of the things that did crop up as a question very early on was looking at your map of the change to the ward layout, that there definitely seemed to be some big challenges there. Were any, my question is, have any structural changes been made at all, or are there any ideas to change any of the layout, or are you having to obviously work around what you've got there?
Not that I know of. So being that the hospital is being redeveloped and rebuilt, and one of the highlights is that there's going to be a significant increase in the number of side rooms. So I'm not sure that anything has come from this, and maybe I need to look into highlighting this to the people who are designing the wards, because the ward itself is lovely, but the layout made it incredibly challenging for the management of these patients. And I think that that point that I mentioned, that education around stroke and the full impact that it has, I think maybe could have been quite important here in developing the ward.
Definitely. I mean, I was aware Julie Winter's got a particular interest in sort of how wards and how new hospitals are designed, and I think this is a good prime example of not the best suited to the clientele, shall we say.
Yeah, it seems that the design now of hospitals, and it's not a bad thing, but it seems that it's been impacted a lot by COVID, and that having, I think the old layout of the ward, I think, allowed for this new layout has more side rooms, so patients are more easily isolated, and which I think is something that's been considered quite a lot, because in the hospital we have one ward where it's all side rooms. So we have to, the CSPs have to think carefully when they put people there, knowing that everyone's in a side room. So I think maybe this is something worth exploring.
So it's a big challenge. I've just noticed there's a question from your colleague Helen saying this is really positive. Were there any staff groups it was more difficult to engage with?
Do you know, I found it actually, there was quite a culture on the ward. When a patient had a fall, it was, oh, someone so-and-so did this and so-and-so did that, and we should have done this and so-and-so should have done that. And it wasn't very a very constructive environment to learn from them. And I found actually it wasn't one group of staff, it was everybody. So I found that after bringing in the falls huddles, there was a lot of change around how a fall was viewed. So when the falls huddles were first brought in, I was very, so I think I could have done this better, and next time I want to be able to do this. Does anybody else have any thoughts? And I think that helped change the going from like the blame game to what can we learn from this, and I saw quite a positive change from that. But I don't think any groups were hard to engage with, and actually what was nice is that the doctors took quite an active role in this as well, and they came to, even though they're very busy, they came to the falls huddles and they engaged with us and discussed what could have happened, even if there was no medical role there, which was nice, I thought.
Yeah, it's good to get a full multidisciplinary input. A question from Becky earlier on was saying that looking at your pie charts on the falls, looking at specifically dementia cropped up quite a bit. Has there been any work to actually break that down to look at what specifically about dementia was the cause within that condition, or is it just dementia as a blanket coverage?
So I think it was listed as one of the highlighted themes. I didn't actually look too closely into it. I think something that I would want to do is go back and look at these day texts, look at the patient notes and see if that, I'm sure it was the case, but just looking at that, I don't think there was any looking into on that, and maybe there would be a role for the dementia specialist nurse in this and looking at highlighting the falls risk in dementia patients. But all of these patients had also had a stroke too, so, and it was not common, but I found in my experience that sometimes patients have had a stroke, they don't have a diagnosis of dementia, but the doctor said they probably had something underlying previous and the stroke has exacerbated that. But that's a very good point, and I would actually quite like to look into that.
Thank you. I just noticed Anne-Marie has asked, did the use of the sensor technology impact the incidence of the falls? Did you notice a change in the number of falls once you started using the alarms?
Yeah, so we started using the alarms in December. So that was when we started looking at the number of falls. That was the December to February was the months that I looked at, and we started using them in December, and the falls prior to using them was 13 in 3 months, and after was 8 in 3 months. But the problem is we implemented lots of things at the same time, so I can't put that down to straight being the falls alarms, but I do think that they were very useful, and if a therapist or a doctor or anyone who worked in the hospital was walking past at the time and that heard that alarm go off, they could immediately get someone's help. So I do think that they had an impact, definitely, but I can't put the reduction just down to them.
Okay, that's multifactorial. Just another note here from Tammy again, saying aware, like you mentioned, that more hospitals are moving towards a larger capacity for side rooms, and does this increase falls? Then my personal observation would be that it could do if you don't address the visibility side of things. I think you are putting people at risk if you don't change the protocols. And then looking at the protocols specifically, looking at your post-fall learning discussions, your huddles, and did the team get any training on how to have these conversations, i.e. moving away from the kind of blame culture and make it a more inclusive discussion and quality improvement?
No, so the team didn't have any training. It was something that was discussed, I think, in the clinical governance meeting with the doctors, therapists, and the nursing and the ward manager, and it was discussed amongst the therapists. So usually the therapist would be leading the huddle, and I discussed it with the therapy team about how was the best way to go about leading that, because when I went to this conference and saw that these falls huddles were being used elsewhere, I actually asked the question, how do you have this conversation with people who are frustrated about the situation, people who not frightened, but who are worried about talking about it. And the answer that they gave me was going in openly and discussing it openly. Discussing it openly with everybody and taking the lead on that. So as I said before, I would say, oh, I think I could have done this. I could have done this for the patient. I could have highlighted this to them. I could put a visual aid out for them for next time. And I think starting it off with the therapy, with the therapists, what they could have done better helped the others in the team talk about what they felt they could have done better, and making sure that the language used was positive and not ever like, well, that's not good enough or things like that, because that's the kind of term that I felt made people feel like they were being blamed, which of course is not the case.
No, I agree wholeheartedly. I think if you've got a no blame culture and everyone is willing to learn, then services can improve. And I think that's a very positive thing to come from it. Yeah. Has anybody else got any burning questions for Maddie, or anything else you want to add at this moment? Simon, should we?
Maddie, it's Simon. Just one quick question. What sort of plans or thoughts have you got around keeping, obviously everyone has so many challenging priorities, competing priorities. How do you keep falls prevention kind of top of mind, if you like, for the team in the stroke unit long term?
I think so. We always mention it. So it never used to be. We always mention it at the clinical governance meetings of how many falls have we had, and it was this audit I did try and carry on and do it over the months, but clinical work did take some priority, unfortunately. I think keeping it at the front of everybody's mind is making sure that we have that visibility of falls awareness. So having up the falls, the board that we had. We also on our ward have the Think Yellow regime, which is every patient who's a falls risk wears yellow socks and has a yellow blanket. The problem is on the stroke unit, a lot of people qualified for that, so a lot of people were in yellow. And I think having it, what I wanted to look at introducing was talking about it at a board round, the patients that were at risk of falls and if they were in a side room or not, or in the bay, and if the nurses and everyone felt like they were managing with that patient. Something else that has come from this is that there's going to be a falls therapy focus group in the hospital that's going to be starting to look at the application of these strategies in other places. Obviously it won't work everywhere because I have adapted this for stroke, but looking at just increasing the overall awareness of falls is very important.
Thank you.
Fantastic, thank you. Oh, and Tammy's on a roll. Tammy has also said with the implementation of PSERF, post-falls huddles will be really important. I think it is something that's becoming more and more recognised as being a positive impact on reducing falls. So I think there's a thumbs up there. I'll put another thumbs up on that one for you.
Did we answer the one on, did the team get any training on how to have these conversations, either learning, not blame? I know you've talked to it quite a lot, Maddie.
Yeah, so I did say that I didn't give any training on that, and maybe in hindsight would have been a good thing to do. But I did talk to the therapy team about how we want to deliver these huddles and what best language that was to use, and the form itself was phrased as in therapy learning points. So what happened, therapy learning points, nursing learning points, medical learning points, summary, and then on the next page was action points. So that's what we had, and I think at the time everybody felt that it was okay.
Okay, excellent. There's one more that snuck in. Did you have a set template for the post-falls learning discussion?
I didn't use a template from anywhere. I made a form myself, which I'm being more than willing to share and post somewhere, so that other people can use it. And I can share that, no problem.
Thank you.
And are you happy for this presentation to be made available to anybody who's interested in either contacting you, or we can put it on the follow-up page?
Yeah, I can put my email somewhere if
you want to pop it in the chat, or I think it's probably the best option, because if it goes onto the recording, then it'll be out there on YouTube for everyone to know your email address, and you don't want that.
So shall I click stop presenting and then I can put that in the chat?
That'll be great. Okay. Another quick question for you. Publish that one. Two more questions coming through, because people can sense I'm going to wind up in a minute. Now they're going to start asking the questions before we leave. Are there other hospitals, wards in your trust that this has been rolled out? If so, has it had the same success?
So no, it hasn't been rolled out yet, but the Therapy Falls focus group is looking at rolling that out and putting it onto other wards, and looking at the feasibility of putting it onto other wards. My hope is that it will have an impact on that, and particularly the Falls huddle. I think that's the most easily put onto other wards, and I think that will be hopefully have a positive impact.
Cool. Just popped your email address into the Q&A, because I'm not sure if everyone can see the chat and the way we've set this up, but
yeah. I mean, Maddie, if it's okay with you, we'll also post it on the Falls Practitioner Network workspace on Futures NHS as well, along with the recording, like we did with the maternity session on Monday. So obviously people can sort of contact you via that as well.
Yep, that's fine.
Fantastic. Well, thank you so much. If there's no more questions, a huge thank you to Maddie for coming on and doing this. It's a very, very valuable piece of work. I'm great that you had a chance to share it. And now you can sit back and relax. And thanks for everyone who joined us. Keep an eye on your emails. You will be having a link sent later on if you've attended, or if you haven't managed to attend, you're going to pick this up later, so you're not seeing it for live. But this will wind up today's session. The next ones we have are in Falls Awareness Week next week on the, I want to say 18th, 19th and 20th. Yeah,
we've got 19th, so
19th.
The Julie's on the 19th, so it's quite good that we sort of finished on the post-falls management question, because actually next week we have a couple of post-falls. So we've got Julie Windsor and Dr. Julie Whitney doing sort of the national perspective on falls management, and then sort of post-falls responses. And then we've got a session from Shona McKinnon from NHS Greater Glasgow and Clyde, who's sharing another QI project but on post-falls management. And then Tara Marshall on the she'll be doing free falling, which is looking at a whole series of algorithms and just sort of evaluating options for you, and you can take from that the learnings that you can take from that hopefully will be useful. Okay.
Thank you very much, everyone, and we shall sign off for now, and have a great Falls Awareness Week next week. We look forward to seeing all your postings on Twitter or X or whatever it's called these days. Just enjoy and go out there and share and have fun. See you soon.
Thanks Maddie.
Thank you.